pathologists. And we're going to have a discussion today, as you know, about thriving in an ACO and how pathologists can confront challenges and maximize opportunities. As you know, healthcare reform is well underway, and nobody expects that anything will be interrupted by any changes that are being planned right now. The delivery for reform is well underway. The private sector is leading the way right now, and there are over 260 ACOs and coordinated care organizations that are out there as we speak today, and more are coming online regularly. The federal sector has 150 ACO programs and another 150 that are pending. In my state of Massachusetts, for whatever reason, we were the first to legislate on this issue, and we recently enacted an ACO law which has some language specifically from the joint activities between CAP and the Massachusetts Society of Pathology. We got a provision in there that clinically integrates the CAP medical director into the ACO. So before the webinar, we put together a survey. We asked the registrants on their level of involvement in an ACO or coordinated care entity. We saw that 29% said they are in the development phase of either an ACO or some form of a coordinated care entity. 6% said they are participating right now in an ACO. 3% said they are participating in some form of a coordinated care entity. 39% said they are neither participating in nor are in the development phase of either an ACO or a coordinated care entity. And 23% said none of these apply to them. So the college continues to increase the visibility of pathologists in the national ACO arena and enhance resources available to members to assist them in maximizing their role in these emerging models. One example of these resources is a recently released white paper entitled Contributions of Pathologists and Accountable Care Organizations, a case study that examines pathologist contributions at 3 diverse coordinated care models. The paper was the focus of a panel discussion which included subject matter experts from Brookings and CMS at the recent CAP annual policy meeting in Washington, D.C. last May. ACOs and coordinated care are also central to the Promising Practice Pathways report CAP released at CAP 12 that describes the new pathologist-driven services and programs that add clinical value outside the laboratory. Indeed, one of these pathways focuses on coordinated population care services. To download that report, you can visit CAP's newly launched member community, CAP Connect, at capconnect.cap.org. So today we were going to hear about the key findings from the ACO white paper from one of the co-authors, David Gross. David is the director of the CAP's Policy Roundtable. The Policy Roundtable was established to allow us to become more thoughtful and more proactive in public policy issues. One of the charges of the Policy Roundtable is to elevate CAP's role in influencing the development of policies that will shape the future of pathology and to increase the visibility of CAP in the public policy arena. A Policy Roundtable committee was formed to help develop and implement an agenda for public policy research and public policy positions that support the practice of pathology. I am fortunate enough to chair that committee. The committee will also be conducting policy research that supports CAP's mission and fills gaps in its policy portfolio. Finally, the committee will prepare white papers and publications as it identifies and develops relevant policy issues. So following David's presentation, we will hear from a pathologist from one of the institutions profiled in the paper, Dr. David Scamurra. Dr. Scamurra is Director of Central Lab Services from Catholic Health and a member of Catholic Medical Partners, CMP. Dr. Scamurra and his team have done a tremendous amount of work on establishing performance measures and the supporting data infrastructure for pathologists in their ACOs. Following the presentations, we will have a question and answer session. You can ask questions by typing your questions in the question box located in the GoToWebinar console. The console should now be displayed on your screens. During the Q&A, the CAP staff will read your questions to myself and the presenters. I've asked the staff to combine similar questions so we can address as many of your issues as possible in our limited time today. Please note that in order to ask a question, you must also be logged into the webinar, not just calling into the audio portion. This webinar is also being recorded and will be available for replay on the CAP website within approximately 1 week. And with that, let's begin by hearing more about the highlights from the ACO white paper from David Gross. David?
Thank you, Dr. Friedberg, and I want to thank all of you for taking the time to call in and tune into our webinar. As Dr. Friedberg said, this is based on a white paper that was written, so I'm just going to be going through some highlights here, and you can read the white paper if you are interested in getting more information. But what I want to do now for the next several minutes is, first of all, make sure that everyone on the line has a common understanding of what ACOs are, and also to reiterate some of what Dr. Friedberg said about why it's important for pathologists to know about them. Then share the main findings from our case study of those 3 ACOs where pathologists have taken leadership roles. In that, we have findings that we also, with our Policy Roundtable Committee, talked about and then discussed some barriers to pathologist success and some opportunities for pathologist success in an ACO environment. And finally, to present some recommendations of public policies that we felt would be useful to enhance pathologists' ability to contribute to the ACO goal of providing greater value for the health dollar. So an ACO we define as a network of health providers who are accountable for the cost and the quality of healthcare services provided to a defined group of patients. And I'm talking very broadly when I say ACO because it's any kind of a collaborative care model, which are alternatives to the traditional fee-for-service model. Instead of being paid for what they do, providers are paid for what they achieve, for the value and how they provide care. Nace and Gartland, who wrote an article that we cite in there, define 3 main features of a coordinated care system. One is it has care delivery reforms, going from a fragmented system to one of clinical integration and coordination of care. It involves payment system reforms that are designed to reward achievement for a set of quality standards. And they have a health information technology system that allow the providers to access information about patient access across different care settings, which allow for implementation of those delivery and payment reforms. And as Dr. Friedberg said, we hear a lot about this in Medicare, but this is something that's growing quite a bit in the private sector as well. So that's what we're talking about. Now, why should pathologists care about this, and can you just ignore it? Well, one, it looks like this change could be widespread, so ignoring is being done at your own risk. But it also has challenges and opportunities for pathologists. The challenge obviously comes from change. That's always threatening. And it's a change from fee-for-service and from the individual approach of practicing toward being a more formal part of the care team. But the opportunities come from the focus on healthcare quality and population health within this coordinated care environment, supported by an information electronic connectivity that offer a chance for pathologists to apply their unique set of skills to helping ACOs achieve their goals across different areas of practice and across different settings. So it's a new way to show value in a world of that has downward pressure on reimbursement rates, but there's a chance to show value in new ways of contributing. And the practice pathways that Dr. Friedberg talked about, how they provide other examples of this, but the coordinated care environment provides one environment to do this. So we wanted to learn more about how some pathologists are successfully operating in these ACOs and to see if there were some common lessons and policy implications from their work. So we visited 3 different ACOs that were chosen because they have a diversity of models and a diversity in how long they've been operating. One of them is the Accountable Care Alliance in Omaha, which is a unique collaboration between an academic medical center, the University of Nebraska Medical Center, and a community hospital, the Methodist Health Systems, which has been operating for about 2 years or so, maybe 2.5 by now, The second, bit longer, is Geisinger Health System in Danville, Pennsylvania, which I'm sure many of you or all of you have heard of. And they've been doing this for over 20 years. And the third is CMP, Catholic Medical Partners in Buffalo, which is, you'll hear more about that from Dr. Scamurra, a partnership of 4 community Catholic hospitals and an IPA, CIPA of Western New York Incorporated. So next slide, please. So now I want to go to the part where we're going to share some of the findings from our study. Again, this is a synthesis. Next, please. So we identified 4 common ways in which pathology and laboratory medicine provided a value add in the ACOs. The first of these was establishing or developing protocols for laboratory ordering, particularly for high-cost tests and high-frequency tests. And what we had heard is that the partnership with clinicians is very important because the clinicians don't always know which tests are appropriate, especially as we get to the more complex genetic tests. And in fragmented systems, the protocols of what tests to use and when vary between sites and even between physicians at the same sites. Now, pathologist contributions in setting these protocols are yet not unique to ACOs, but ACOs are unique because you have the ability, an institutional ability, to put in applying similar standards across a wide range of settings, and to put in financial incentives in place, both to reward pathologists for developing these and to promote compliance. Compliance is, or these protocols were done in different ways, but I think the key word is consultation, always in consultation with other providers. Sometimes formal consultation, sometimes informal, sometimes based on clinical consensus, and sometimes based on examination of research, an evidence-based approach. But the outcome of this is savings is achieved by decreasing unnecessary tests, improvements in treatment by getting the right test more frequently. And we have some examples of how that has been applied. The second finding was pathologists were making contributions in population health management, applying their expertise to developing standards for identifying and managing chronic illness among patients enrolled in the health system. Geisinger, I think, among the 3 was the one that made the most progress in this, which they have great access to data. They've been doing this a long time. We have examples of some of the impacts that they've been able to have, such as reducing median days that renal patients were on EPO to reach a target hemoglobin level. Went from 62.5 to 35 days on average, saving $2,200 a year per patient. They were able to help with diabetes treatment guidelines that led to a 1/3 increase in the percentage of getting flu shots, a 40% increase in percentage getting pneumococcal vaccines, a 46% increase in blood pressure goals. So this can also lead to, obviously, better health outcomes, less other kinds of treatments. A third place where pathologists were contributing, were taking a leadership role in improving access to actionable data, designing the format for lab results in the electronic health record and in the HIE to make it more actionable. One of the pathologists we spoke with at Geisinger said that they thought that and I believe this was an anatomic pathology, the lab report was the most important product they produced, and they were spending so much time on trying to format it, trying to communicate it so that the doctor can take action. And in a team, they have support for doing that kind of a thing. And the final thing we observed was so much collaboration, which was the key to success that all the people we talked to told us. And I should add that we didn't just talk to pathologists. We talked to other providers. We were able to talk to ACO administrators in these institutions so we could get a broader viewpoint. And the things we were hearing were both from pathologists and the other providers and the administrators. But collaboration gets buy-in and adoption. And the pathologists here proactively were engaging. They came out and said, we want to be able to help you. And in an ACO environment, the administrators have the ability to incentivize collaboration and compliance by the clinicians to these standards. Now, it would be great if everybody was able to do this, but there are challenges that both pathologists and ACOs are facing. One, of course, is how do you pay the pathologists? And we have different degrees of success here. I think the big story is the problem is not solved yet. Geisinger probably was the closest. They have a long-standing coordinated care system. Everybody is salaried there, and there's incentives, whether you're a pathologist or not, but the financial incentives are substantial for innovation and for improving quality and outcomes. In the Omaha ACO, both at the medical center, the University Medical Center, and the community hospital, the pathologists are salaried, but the bonus systems are yet to be determined. There's a sense that pathologists will be eligible for shared savings and bonuses, but the administration and the pathologists have not figured that out yet. Catholic Medical Partners, CMP, offers different challenges because there the pathologists are not employees of the hospital, and they're not directly compensated for increases in quality, and the incentive payments are still a work in progress, and Dr. Scamurra can fill us more on that if that comes up. Another thing to success is the HIT system. These systems have to be bidirectional, and you need a good system to achieve the outcomes discussed earlier. Geisinger, I think, again, is the most advanced, and even they say this takes a lot of time, it takes a lot of money. They're still working on it. But the HIT systems allow for tracking of orders, for tracking of test status, for providing results, for interpretive reports. The interface barriers we found still exist. Sometimes hard for the clinician to get actionable data. Now, often it falls to a clinical laboratory to solve these problems. There's a sense that eventually this will be done, but again, that's going to take a lot of time and money, and all the institutions we talk to identify these as challenges. The third challenge was culture change, and everyone agreed that this is a challenge. Pathologists have to get out of the basement and out of the lab and see new roles for themselves in a collaborative care model. Dr. Scamurra had told us about retraining that has to be done on communication and collaboration. But this is two ways. The other clinicians and administrators also need to reframe the way they're thinking about pathologists. For those who don't understand the value and the contributions, also have to be seen to think that pathologists can be partners and can help them improve their outcomes as well. So, barriers and opportunities for pathologist success. We got this information, but we also had a review panel of members of the Policy Roundtable Committee and also Dr. Karcher from GW, who heads the ACO network that I'll talk about in a minute. They agree that as ACOs become more prevalent, pathologists have the opportunity to expand the kinds of services they provide and to have an even greater impact on patient care than they do now. They, again, as I talk about monitoring the status, detecting illnesses, facilitating innovations. But, next slide, there are barriers to widespread adoption of this at this point. Many practices, particularly smaller and medium-sized practices, may lack the expertise needed to make these kinds of contributions, particularly in molecular testing and in informatics. Some of these practices, it's a problem being the question of being a jack of all trades versus specialization in certain areas. And it's very important because the important thing is how to pay for this enhanced expertise if practices want to get it to beat an ACO, because we don't yet know how the incentives are going to be paid out. We don't know if there's going to be cost savings for sure. Are they going to be invested in things like HIT, or are they going to be shared savings? So it's not all rosy. We are aware of some of the issues that can come about. Now, we do have recommendations for pathologists who want to be active in ACOs based on the interviews that we had. Again, all of the people told us, be proactive. reach out to the local organizers and leaders. Don't wait to be asked. Let them know, because they might not realize how you can contribute. Explain how pathology and laboratory medicine can contribute to the goals. Step up and seek leaderships in the committees. Find out how to do this by joining CAP's ACO network, which there's going to be another slide that tells you a little bit more about that, but here you have the website on how to get involved. And document how you've contributed to better outcomes if you've been able to do this. When we talked to Dr. Scamurra, he happened to be chatting with about a case where a doctor had ordered a very expensive test that he thought might have questionable utility. He called up the doctor. He said, yeah, no, I didn't realize that was very expensive. We don't really need that test, saving money. And the administrator, who was a big supporter of Dr. Scamurra, who was listening to this conversation, said, I didn't know you did this. He said, these are the things you do. So documenting is also very important. Let me go now on policy recommendations, because we can do a lot ourselves, but there are some policies that we think can enhance pathologists' ability to contribute. One of these, which is something that Dr. Friedberg mentioned, happened in Massachusetts, is to have an advisory board. The ACO has to have some kind of or should have some kind of body that recommends the protocols and the testing guidelines. Those savings and increases in quality can't occur without a process for recommending guidelines, and that process should involve other clinicians and be respected by other clinicians, and should be led by a pathologist, somebody with this expertise. Many institutions have these already. Several states have been considering legislation. Massachusetts, working with the Massachusetts Society of Pathologists, did get that language approved. And note that this is not saying that the guidelines should be set in regulation, but that the ACOs, to provide good care, should have a process for setting the guidelines. Our second recommendation is that CMS should encourage or recommend that at a minimum, all relevant providers, including pathologists, should have easy access to information on patient health care status, the care plan, and the results. This would be reducing medical errors, reduce unnecessary duplication of services, reduce underuse of appropriate services, and is vital to what the pathologist does and to the success of the ACO in having the bidirectional information. The third is, if ACOs have value, we think that they should be available throughout the country, and CMS is taking actions to help promote them in rural areas and other less popular areas. We urge them to keep studying these and to make sure that those are appropriate measures. Those areas have greater risk for ACOs, higher startup costs, and I think that's a good thing to continue. So finally, in closing, I want to make you aware of resources for CAP members who work in a facility that is currently part of an ACO or is going to be part of an ACO. We urge you to join this network to be able to share information and knowledge with other pathologists. You can email aco@cap.org. I believe we have over 40 pathologists currently in that network. And if I'm wrong, someone's going to knock on my door and tell me. Also, we do have an online resource center on cap.org. And so if you click this link, which should be in the slides, you can get some more information on that, which also might be good if you just want to learn something about it, but you're not yet getting involved, as many of you are not yet. And so I hope that's helpful, and I will turn it over to Dr. Friedberg.
All right, thank you very much, David, for the presentation. Now, Dr. Scamurra, I'd like to hand over the webinar to you so that you can provide us with some of the details of your experience with the Catholic medical pathologists.
Okay, thank you everybody for attending. We can go to the first slide. Oops, we can go to the second slide. Okay, the key features, let me just briefly describe my group and our hospital and what the IPA really is all about. Our group is a 14-person group. We're independent. We contract with our 4-hospital system, which is about half the work in the city here. to provide pathology services. We have an exclusive contract. We bill for Part B. We receive a Part A stipend for each of the 4 hospitals. We also own a private laboratory which does biopsies from outpatient offices and pap smears and various tests associated with those. We do immunohistochemistry there for the system. That's wholly owned by our group. So that's basically our fundamental structure. The Catholic Medical Partners evolved out of something called the Catholic IPA. And this is something I was involved with pretty heavily about 10, 12 years ago, and it is a LLC owned by the physicians in the hospitals. It was put together to negotiate the managed care contracts for all the hospitals and the physicians. We evolved over the years to change the way in which we were doing things, and our purpose was to change the way in which we interacted with each other. So over the years, we have been initiating many incentive programs and have diverted a lot of money into incentive programs for our doctors in the hospitals. Currently, the Catholic Medical Partners has about 950 docs. 90% of them have adopted EHRs through various grants and efforts that the CMP has made. We have 30 level 3 patient-centered medical homes, and we have got a couple hundred care coordinators that are dispersed among those to go into people's houses. So we're pretty far along. The only reason I bring that up is to point out that incentives have been there for quite a while. You can go to the next slide, please. And go to the next slide. Okay. The dilemma that we have right now is that the incentives that we had up to this point have been for pretty much piecemeal kinds of things. And the issue with the ACO now is that it's a bundled kind of a payment. And so the relationship that pathology has now to the reimbursement and to the patient is completely different. The question now is, how do you fit into a particular continuum of care in any patient encounter, as opposed to how many 8305s you're doing? So you're being evaluated into what is your worth in the process of taking care of any given patient over a period of time. That's a very difficult thing to explain, and has a lot to do with what is Part A and what is our relationship to these tests, and how can we demonstrate and quantitate what Part A means to healthcare and to quality and to cost. You can go to the next slide, please. Go to the next slide. One of the problems with the ACO model when it gets into this bundled payment, I'll touch on this on the end too, is that the driving force is often discussed in terms of flattening the cost curve or decreasing costs. And if you have that as the primary driving force of the ACO, and you get involved with your ACO, this is going to come up. You need to stress that the purpose is not to simply cut the cost, because if you go with that sort of mentality, when a pathologist or hospital-based physician goes into those kinds of situations, it's very difficult to prove your worth, and you are become basically a commodity and a cost target. And so it's important that you be able to explain the things that we do best to the ACO administrators and figure out a way in which to reimburse that over a period of time through this bundled payment system. You can go to the next slide, please. And the next one. Part A and Part B are two of the parts which define our services. In Part A, I like to look at under two circumstances. And one of these is kind of the baseline quality that we provide to the practice of medicine, which is we are responsible for the quality, for the dependability, and for the advancement of the lab services for the doctors who are using it. And we have a great deal of skill and knowledge in that area, and it's the kind of thing that is very hard to quantitate. And I can tell you the way we approached it over the last couple of years and the way we're approaching going forward as a group is to say, okay, ACO, we are being provided a quality service, a management service, and a liaison service and an education service in this very big part of healthcare, which is called lab medicine. And we, the pathologists, are the stewards of that. And although you can't measure impact of that directly, it is manifested, or a surrogate measure of that has to do with our own personal education and our participation in our results in proficiency testing. So we have implemented, and we do receive now, incentive payments from the SIPA and in the future the ACO based on our CME credits based on our participation and successful completion of proficiency testing for each individual, and based on the number of lectures that we are delivering to the medical staff in the terms of grand rounds or whatever, in terms of different lab tests and different laboratory medical kinds of things. So in a way, that defines sort of a traditional Part A concept to the people who hold the money now about what we are doing. It's something they can measure, and it's something that we can be reimbursed for. You can go to the next slide, please. And the next one. You can go to the next slide. The second part of the, you can go to incentive plan 1, yeah. The second part of the Part A kind of thing is sort of like a component of Part B for Part A, and that has to do with really more of a direct interaction that the pathologists are going to have with the clinicians, and a direct impact on cost containment and on utilization review. Now, over the years, we've done that by reviewing various lab tests that the system doctors order. I've done this by reviewing several hundred charts and various different things like Clostridium difficile testing, D-dimer testing, cardiac markers, measured how the physicians are using it, measured on the ancillary tests that they generate from those tests, and then trying to figure out if there's a better way for them to order these tests. Now, the impact of that on the program is twofold. One, it shows how the doctors are using tests. Two, it gives the ACO or the administrators guidelines and protocols that they can then say are the system protocols they can then use as incentive programs for the clinicians ordering the tests. You have defined the way in which these tests are to be ordered. And by incenting the doctors through this, providing this kind of information to the administrators of the ACO, allows the ACO to develop incentive programs for those doctors which will more directly impact utilization and theoretically cost. Now, a caveat of that, the first couple that we did like that, I did a few studies, and the incentive was broken up into various components. And one of the components of that study was the successful implementation of the changes that were recommended. Now, the problem with that sort of a situation is that as the pathologist, I don't really have the ability to directly impact that. So when you go and talk about these various incentive plans and different studies and things, I think you have to be careful what it is that you are promising to do. You can't promise to do things or have your incentive programs in areas that you can't directly impact. The latest one that we're working on right now is developing oncology protocols for tumor marker testing. I've spent the last couple months meeting with each one of our oncologists, going over the various ASCO and ACCN guidelines and establishing what tests the system or the ACO are going to accept as valid and which basket of tests are not valid. And I found out one interesting thing was very many of the oncologists I talked to weren't very aware or read up on their own ASCO guidelines. And there was quite a bit of a gap of knowledge there that I think that we could fill as the pathologists and help the ACO develop these kinds of standards. The ACO will then use these standards later to develop an incentive program for the oncologists to ensure that they are staying within those limits and they're not ordering tests that we feel are not indicated or not necessary. You can go to the next slide. This is an example of the incentive plan 1, where I would do 2 studies a year on some D-dimer or whatever that was broken up into 25% to propose a topic, 25% to collect the data, 25% to present it to the physicians, and then 25% to integrate the findings into the workflow. And it's that last bullet point, I think, that you need to be aware of, that I don't have much way of impacting. We actually lost that part of the incentive in those early days. You can go to the next slide, to incentive plan 2. And this is the oncology program that I'm telling you about. And the idea here, just kind of working through it, shows you how we're establishing tests that are acceptable, tests that are not acceptable, You limit this ordering to oncologists and pathologists and get it approved to the medical execs of the system and the ACO, and establish it as your baseline and as your guidelines going forward for adequate care. And these are the things that the ACO administrators are going to look for you to be able to do, and things that you can do, and help establish these kinds of measures that they need in order to have an intelligent control over utilization by the doctors in the plan. You can go to the next slide, please. And pitfalls. You're right. You don't want to be measured by reduction in test volume by the success or failure of your own incentive plan. Just for the reasons that I just mentioned. There are all kinds of questions that have to be answered here as to how far pathology can go in getting involved in this area, malpractice issues, cultural issues, but I think you're best left with being able to organize the data, analyze the data, present what's happening with a given test in terms of utilization review. You work as the liaison with the physicians and give lectures to explain how best to use these tests. Work with the ACO to establish these tests as guidelines for the physicians to order properly, and that the ACO administrators can then use as incentive guidelines to be sure that the physicians are ordering properly. You can go to the next test. Next slide, please. I think that these things are all things that have been said. This stuff is here. The bundled payment does change the dynamic from just simple fee for service with incentive on top to really what you're worth in any given kind of a situation. You have to be able to explain the Part A concept of what we do in the lab and translate that into something measurable to translate into some revenue stream for yourself. We've done that, again, like I said, by targeting proficiency testing, lectures that we're giving, and CME credits that reflect our ability to impact that level of quality in the lab. That's how we can document our contributions in that way. And then getting involved with the physicians in a face-to-face manner in terms of developing guidelines for them to use. I think that's it. Okay, that's all.
Okay, now it's time to move on to the Q&A portion of our session. So as described earlier, please send us your questions electronically through the question dialog box located at the bottom of your console. As a reminder, you must also be logged onto this webinar console to ask a question. Julie, can you begin with the first question, please?
Sure, Dr. Friedberg. I think this is probably a question, a perspective from all the speakers. ACOs appear to be similar to capitation models of the 80s. What would the speakers say the differences are? Dr. Friedberg, do you want to start us off?
Well, let me toss it one over to Dr. Scamurra first, see if he has a comment on that one.
Okay.
Yeah, we had one of our first couple of things was a capitated model, and I think, you know, the fundamental idea from the person giving you the check is the same in the sense that they want to write one check and be done with it, and that's what, and then kind of leave it up to you to figure out how to do it. The ACO models, I guess, in a superficial structure are similar to that, although I think that what you have now is you're dragging more and more into, you know, the ancillary stuff like the radiology and the pathology and the dermatology and all the things before. The capitated models we had were pretty much related to primary care and some of the major surgical specialties. And I think that when you throw in hospital-based like this, it gets a little bit more confusing as to what you're worth in any particular moment. So if you're not salaried, like we're not salaried, it becomes an issue trying to figure out how much of that pot you get. I think we weren't really involved directly in the pot that we had before in terms of a capitated model. Now we're more directly involved. So to me, that's the difference at this point.
Okay. And this is Dave Gross. I'll add that, and again, I'm not a practicing physician, I'm an economist, but I think that the capitation and the managed care movement eventually became more about managing costs and not managing care. At least the structure of the ACO and the coordinated care movement is to reward or incentivize the providers and the institutions for cost reduction, but also for improvements in quality of care and better outcomes, and perhaps reducing unnecessary services while making sure that you're keeping necessary services, sometimes increasing services that aren't being provided. At least that's the aim of it.
And this is Dr. Friedberg here speaking. The way that I would look at it is that under the HMO model, it was basically the payer who was just trying to pay less. Whereas if you think about the term accountable care, the implication is that nobody was accountable in the previous days. I think I prefer to think of it as more of a coordinated care model where we're trying to get the providers to coordinate their care to improve the efficiency instead of simply having the payer shoulder the blame.
Our next question, I believe, is directed to Dr. Scamurra. If an algorithm for proper use of molecular tests is developed, how do you measure success except by comparing current molecular test volumes to historical volumes prior to ACO? Doesn't this get you into measurement by test volume, which we should avoid?
Can you just repeat that just one more time for me? I'm sorry.
Sure, it's a long question. If an algorithm for proper use of molecular tests is developed, how do you measure success except for comparing current molecular test volumes to historical volumes prior to the ACO? Doesn't this get you into measurement by test volume, which you had advised to avoid?
No, I didn't advise to avoid it. I said I advised that if you as the pathology group contract to study this and provide algorithms, that the success of your contribution to that process should be measured only on the fact that you did the study, it was accurate, and you presented the data to the ACO people. What I cautioned against was if part of your incentive is to have the clinicians actually appropriately reduce the volume, but the medical leadership takes no action to enforce your suggestions, you should not be held accountable or measured as successing or failing as the pathologist in that situation by whether the volume goes up or down. That, in a way, to me, as I go through this the last couple of years, and I think the leaders of this ACO are starting to understand what I'm saying. I can have access to the data. I have knowledge of the test. I have access to the patient's charts, and I can show you what happened. I can show you what, a good algorithm of this is, and you're going to get a better outcome. Now, if that's the case and you want to adopt that and turn to your primary care docs and say, this is the way you will order D-dimer, or your emergency room docs, this is how you will order D-dimers, and they refuse to do it, and the D-dimers stay up, well, that's not my fault. I didn't fail there. Therefore, I still get my incentive. That's all I was saying. So yes, if it's appropriate, the volume of the test should go down. Yes, absolutely. So, and that's up to the ACO to measure, but that's a measure more of the success of the implementation of that pathology suggestion to the ordering clinicians. That's their measure of success, but that's not on my back. That's all I'm saying. I hope that makes sense.
Question, thoughts from Dr. Friedberg and Dr. Scamurra about how should small 1 to 2 provider practices get involved in ACOs? The attendee says that all the hospitals in our region have contracted or employed pathologists. So they're wondering how, as an independent provider that serves mostly outpatient providers, how they may get involved in ACOs, and wondering if you have any thoughts on that. Dr. Friedberg?
Yeah, that's a tough one because there's you're providing a service that somebody else may already have contracted, and I think you need to identify in what ways can you add a unique service. I mean, if you're simply replicating something that of an equal quality that's available on under a contractual basis, you know, it's going to be a tough sell. And I'm not sure exactly how what you'll be able to do about that, other than to try to figure out a way to work with the groups that are there. Now, a lot of the smaller groups are trying to figure out whether becoming a larger group is in their interest, or what may happen is something that you've seen, for example, among cardiac surgeons, where in the space of a handful of years, they went from roughly 80% of them being in private practice to roughly 80% of them being employed, because they couldn't find the answer to that question.
Yeah, I was going to say the same thing. I think that a lot of the clinicians, you see them forming groups and selling their practices to hospitals for that reason. But I think that if you're by yourself like that and you've got an issue, you've got something, or clinicians who trust you, and you're doing a good job. This is where I go back to that whole thing about don't let the ACO come at you and say this is all about cost. You've got to have a quality thing. This is not about cutting costs. This is about re-engineering healthcare to make it more efficient and make it better, not to just cut the cost. Therefore, if you can go to the people who use you, and those people are in an ACO, and you can make the case that you do have a value-added service, that you do respond to them quicker, that for whatever reasons you can make it, that ACO is obligated to contract out for those services in one way, shape, or form. And whether you can be called in-network for that ACO or not is going to depend a little bit on your ability to have the people who use you go to bat with you with the ACO administration and say, no, 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 this little small lab is going to add quality and is more cost efficient than the big lab across the street. So in that sense, that is a way in which that can happen, because the ACO should not just simply be looking at cost. It should be looking at a bunch of other things when it comes to things like lab. So that's the argument I would make, and that's the route I would take. I would talk to your clients and see if they're in an ACO and go from there.
I would just reiterate that one thing to focus on is, you know, the words coordinated and/or accountable, because it's not going to be simply, you can't let it become a commodity where it's the cheapest product regardless of quality. If that happens, we're all in a world of hurt. But there's you know, as long as you can stress either some component of the accountability of the result and the information or the service, or just the coordination of it, depending upon how your local environment, that's what should be the key part of the operation, not just who can give me an answer at the decimal point to the cheapest rate.
Right, right.
And I'm going to agree with both the doctors and also say that you know, another thought in figuring out how to add that value, and this is more of a longer range solution than short term, but to go back to the promising pathways for pathologists that Dr. Friedberg mentioned earlier, which is an attempt to think through possible directions that different kinds of practices might think about for their business model in the future. Is it going to be in coordinated care? Is it going to be in high-quality diagnostic services or some other things? And that I've just urged the questioner or people in those practices to think about that as well as they're thinking about how are we going to add value in this changing environment.
Dr. Scamurra, I have another question from an attendee who says, our group is similar to yours. We have become so busy with anatomic pathology that there isn't much time for administration. How do you manage this? It sounds like you personally have administrative time, or it sounds like this takes quite a bit of administrative time to manage.
Well, this goes back, well, let me just put it this way. I have a lot of energy. So, I mean, I do a full load of AP, and I do all this contract. I get this done pretty much. I've got a lot of contacts, and we work through it. But it also goes, as this evolves, there is a re-education of your partners that needs to occur. And they need to start pitching in. They need to start understanding if they're APCP, they've got to start taking some roles in these situations, that your purpose hasn't changed, but the way people are looking at you has changed. You have to do things a little bit differently. So it depends on, you know, your organizational abilities and your energy levels and your contacts and on what you're going to do. I don't know what else to tell you. You have to do it. And sitting in your room and reading your slides and going home at the end of the day isn't going to cut it anymore. It's just not. And you're going to have to go out and participate with the clinicians in other ways in which you can, redirect the incentive dollars back to your group. I guess the best thing I can say is it has to be done. Look among yourselves and talk about it and see who can take the lead there. It does take a lot of time, and there's a lot of back and forth, yes. Yeah. But it has to be done, and someone's got to do it, so that's your choice. No good answer, I guess.
Another question, I think for thoughts from both Dr. Scamurra and Friedberg. When negotiating the value added by pathologist consultation and laboratory testing, how should the bonus be structured, or what percentage of the bundle is provided to pathology? Have either of you seen any formulas that have been used or models that might be recommended?
I haven't seen anything I can recommend. David?
No, I haven't seen any formal models. I mean, there are, we just sit down at the table and argue about it. I mean, when I got off the board, I mean, you got to figure, like, our Catholic medical partners at the end of 2 years ago, when I'm not on the board, my terms were up, we had about $35 million in incentive dollars to distribute, and everybody's sitting around the table. So it's a discussion. But you have to be able, you got to bring something to the table. You got to have something tangible. You got to be able to show that you are important. I think this concept of maintaining the quality, dependability, reliability of the tests, coupled with your ability to liaison, educate, and your ability to take the data and provide guidelines and parameters to measure the ACO docs in terms of their lab utilization, are things that you can package in a cohesive way that are tangible, that you can sit down and say, this is worth something, and then go from there.
But one thing you can't do, or I recommend you do not do, is go there and say, well, I made this much last year, and so I need to have this from you in order to make the same amount this year.
I would agree with that.
I think you need to be sure to have some measure of your impact, some way to give them the sense of, how much better off they are because you are there as opposed to not being there. And depending on who your competitor is, you can use their alternatives and say, okay, if you want to take this alternative, this is what you would like to get out of these situations, a particular situation. And that may be another way to structure the negotiations is what are their alternatives and what would that cost?
Yeah.
We've had a few questions on Part B, fee for service in an ACO environment. Dr. Scamurra, do you know how the ACO model affects these services?
Right now, I don't. Right now, we're still billing. I mean, the shared services thing just started this year, so we're discussing that. Right now, they're kind of focusing on primary care and the patient-centered homes, and my conversations with our medical director and the president of the ACO basically are, okay, now we got to sit and talk about hospital-based lab in particular, and how is this going to work? I mean, look at it this way. I mean, if they're going to turn around to an orthopedic surgeon and say, okay, here's your $3,000 for the knee case, and here's the list of expenses, and one of the expenses is $40 for the pathologist to look at knee scrapings, what do you think is going to happen? That's going away. So, that's the kind of stuff that's going to go on. And you got to be aware of that, and you got to be able to, I'm not sure. I was telling my group the other night, we were talking about starting a molecular lab up. I mean, I'm not sure Part B is going to be in its full form in a couple of years. I think a lot of, I think isn't in Massachusetts they're going away with component billing or something like that? Yeah,
here in Massachusetts, the ACO legislation, which is really a primary care medical home legislation, has a comment in there about getting rid of fee-for-service by 2015. Keep in mind that some portion of the fee-for-service infrastructure is going to have to be retained in order to get people to document what they have done in order to have, for some bundling to determine where some dollars are going to flow. So part of the system for fee-for-service will remain. The question is, are you really going to be able to tally up, X times 88305 for, and figure out a paycheck based on that? And so, if that's the real issue here, part of the system will remain, but whether the dollars are there or they're more on the other side, you can sort of think of it as a massive B to A shift of where you're going to have to document it through a different mechanism if you want to get the dollars that are coming in onto the newer system.
I would agree with that. I think that's what's going to sort of shift over. The Part B is going to shrink. The Part A is going to grow. They're going to want that value-added stuff. They're going to want you contributing to the overall care of that patient, and that's where you should direct your energies.
And the more that you can ascertain that you are seen as a physician in the equation instead of a technician, I think is a fundamental argument behind Part A support. I've seen places that have simply said to the hospitals or to the people they're working with, in order to provide these services, I need to have the following people. I need to have 1.2 blood bankers. I need to have 0.75 clinical chemists. I need to have a certain percentage of this and that. And then say, and the average salary for these people in this area is such and such, and therefore that's the A arrangement I need. And if you're going to give me less than that, then we will not have a blood bank here, or we will not have the coag consult, or we will not have the following services. From an interesting point of view, one thing that gets difficult very quickly, and it's a whole different discussion, is the traditional anatomic path non-paid services, such as autopsy, which is something which is going to be even more difficult to justify.
Yeah.
Okay, one last question. We have time for one last question. Is there any mechanism for discovering or understanding the size of the total available incentive payment for all the physicians in an ACO?
I'm not sure why that would have to be public information. I would fully expect, by the way, that when you got 100 ACOs, you got 100 models, and I think we should probably envisage this as being sort of like the computer era was, personal computer era was back in say about 81, 82, where there were 1,500 different manufacturers, and everybody had a slightly different system, and over a handful of years, something rose to the top. We just don't know what that's going to be.
Yeah, I don't know. I don't have an answer for that, really. I mean, it's local. It's what's there. The higher you're up on the food chain, the more you're going to know about the economics in that organization.
All right, well, it looks like we're about time, so I'd like to thank all the attendees for joining us this afternoon. Before we sign off, I want to encourage all attendees to attend the 2013 CAP Policy Meeting, May 6th through 8th in Washington, D.C. This members-only event is an important opportunity to engage and discuss key health policy issues such as delivery reform that are impacting the specialty pathology with lawmakers, CAP leaders, healthcare policy decision makers, and colleagues. This webinar was recorded and will be available for download at the www.cap.org/advocacy website. And this concludes today's webinar on how pathologists can participate in ACOs and other coordinated care entities. I'd like to thank especially David Scamurra and David Gross for joining me on this call, and thank you all for attending.